and I'll make sure that my lecture won't be a neck pain to you or pain in the neck to you. Right. Neck pain, as you know, is a very common symptom, but compared to lower back pain, the incidence or the occurrence is less common. And one of the advantages or one of the positive factors we see among patients with neck pain compared to lower back pain is that the amount of requests we get for leave is less. So therefore, all over the world, people who are caring for neck pain feel that the economic impact from neck pain is less than that of lower back pain. Today we are talking about neck pain in our country. Where are we? I'm sad to say that the numbers are fast increasing. Every year the numbers are increasing very rapidly. What are the reasons? Well, if you ask me, I'm blaming three types of equipment for this. One is a computer. If you see the number of neck pains which came to hospitals or to general practice for treatment, during the pre-computer era and the present computer era, there's a huge difference. Why does computers give neck pain? Well, of course, it's due to posture. People are glued to their computers for hours and hours, some due to their profession, the others due to other reasons like recreation. And today we see the neck pain come in epidemic proportions, particularly among those who use computers for many hours during the day. The second equipment is a television. Again, if I talk to my senior colleagues who have been in medical practice or general practice, they admit that the number of neck pains we saw were much less. It was spondylosis we saw. But again, the television has made people addicted to it, and again you see people going to various postures to enjoy TV, and although they enjoy the program long term, they have to suffer due to neck pain and also due to lower back pain. The third piece of equipment which is very much injurious to our body is a mobile phone. I'm sure you read a lot of articles about hazards of using mobile phones. As a rheumatologist, one of the main problems I have is the problems with the hand and the neck. And again, I'm sure you must be having your kids, your nephews, nieces, with the younger generation. They spend hours with their mobile phones, and even as a teacher, I'm very sad to say that among my undergraduates, whenever they are asked to stay out for a few minutes, all of them are very busy with their mobile phones. So static postures are becoming more and more commoner, which has resulted in neck pain. So therefore, this important clinical problem, I thought I will present to you under three main headings. I'll spend a few minutes on the causes, what exactly causes neck pain, what type of pathology you see. Secondly, I thought I will talk a little bit about anatomy, and then I'll straightaway move on to the main theme as to how a GP should take care of patients who present to them to their GP practice. What are the causes of neck pain? Like pain in any other part in the body, if someone asks you pain in a particular region of the body, it can be mainly discussed under two main headings. The first is the pain is due to a structure involved in the discussed area. So a lot of diseases can affect the neck, which can result in neck pain, which I had got on this slide, and you are very familiar with these names. But we should not forget that generalized systemic diseases outside the neck can have changes occurring in the neck, resulting in people to present with pain. Cervical strain, again, posture-induced neck pain. It usually comes with backache. That's posture. The general systemic diseases are malignancies. I do come across sometimes, occasionally, people with the past history of malignancies, breast cancers, lung carcinomas, prostate carcinomas, all of a sudden coming with neck pain. Angina is a very important thing. I'll discuss with you when you are taking history. The patient says the neck pain comes on with exercise. You have to think of angina, because you can remember from undergraduate days we have been taught ischemic heart disease can be felt in the region of the back of the neck. Infections, one should not forget. Pharyngeal abscesses, paratonsil abscesses, any of these the pus can track to the soft tissues around the cervical spine, which can lead in neck pain. And of course, in rheumatology, one of the important things is rheumatoid arthritis. Long-term rheumatoid arthritis not only damages the joints in your hands and the feet, but it can also join certain very delicate structures in the upper end of the cervical spine. All of you have heard about the atlantoaxial subluxation. So therefore, if you have a rheumatoid arthritis coming to with multiple joint deformities, and also coming neck pain, you have to think of that complication. Rarely in our part of the world, particularly elderly, we have polymyalgia rheumatica who come with a neck pain, and also there are some neurological syndromes which can come with neck pain. So these are the systemic conditions or generalized illnesses where neck pain can be part of the illness. For us to understand better about neck pain, particularly about its management, I thought I'll take you through the anatomy of the cervical spine. Cervical spine is the uppermost component of the vertebral column, and you know that is the most mobile part. That is why cervical spondylosis and all these sprains and mechanical problems are common in the neck, because that is the most mobile component of the vertebral column. It is made of 7 cervical vertebrae, and the 2 adjacent vertebrae are linked to each other through 3 joints. You get one joint anteriorly, what you call as the intervertebral disc joint, which binds one vertebral body to the other, and posteriorly you get a couple of joints, what you call as the zygoapophyseal joints, where the superior articular processes of the vertebra below articulates with the inferior articular processes of the vertebra above, and that makes what you call as a facet joint. So therefore in the cervical spine there are 2 sets of joints that we have to think of. One set of joints are situated anteriorly, which are the intervertebral disc joints, and the other set of joints are situated posteriorly, what you call as the facet joints. In cervical spondylosis, which occurs in the elderly, commonly both the facet joints and the intervertebral disc joints are affected. One should not forget that the functions of the cervical spine is not only to give us a rigid or erect posture, but it also gives protection to the spinal cord, and also at each segment 2 spinal nerve roots emerge from the spinal cord, and they leave the vertebral column through the interval foramina. So therefore it's easy to understand that if there is a major pathology in the cervical spine, it can affect the cervical nerve root as well as the spinal cord. And the C5, 6, 7, 8 and T1 nerve roots, they join with each other from the brachial plexus arch, which provides which gives a motor supply and takes sensation from the upper limb. So that's about the cervical nerve roots. And one should not forget that one of the arteries which takes blood from the heart to the brain go through these very specific foramina of the vertebral column and the vertebral artery too. There are 2 vertebral arteries on either side of the spine, which is quite related to the cervical spine. And any problems, any disturbance to this vertebral artery can disturb cerebral circulation, which can lead to a variety of neurological symptoms and signs. One should not forget that there are loads and loads of muscles around the neck, and the terms what you call as postural neck pain, mechanical neck pain, all these terms we use for those pains which arise from the muscles and also from the ligaments. So there are many signs from which pain can arise in people who come to us with neck pain. Another important fact worth remembering is that physicists who have done a lot of research along with rheumatologists and orthopedic surgeons have clearly shown that if you look at the distribution of the load down the cervical spine, the maximum load is distributed between the 4th and the 7th cervical vertebrae. So when we are talking, when we are moving our neck, when we are doing all sorts of activities, most of the load of the head is focused to that region. Therefore, it is easy to understand that whenever we have a problem related to loading on the neck, like cervical spondylosis or even postural neck pain, the common nerve roots which are involved are those nerve roots which emerge between the C4 and the C7 segment. So therefore, the message I want to give you is that whenever a person has got either a mechanical cervical spondylosis or postural neck pain, the common roots which are involved are C5, C6 and the C7 nerve roots. Having understood the anatomy, let us try to do a anatomical clinical correlation. What happens? What happens when there is a significant pathology in the cervical spine? What type of clinical features will we expect? First and foremost, as I told you, cervical spine is a mobile structure. There are joints in it. So therefore, when the cervical spine is involved in any disease, it's very common to get pain in the back of the neck along with stiffness. That is because the joints, the muscles and ligaments are involved. So pain and stiffness is a common symptom when the cervical spine is involved. We are quite aware that the spinal cord and the nerve roots are very closely related to the cervical spine. So therefore, certain diseases, again cervical spondylosis and other diseases, can pinch these nerve roots, which the signs and symptoms we do get after that is radiculopathy. So and as I told you, C4 to C5, C6, C7 are the common nerve roots which are pinched, and you will know from anatomy these are the 3 nerve roots which forms the brachial plexuses, and that is the very reason as to why people with problems in their cervical spine commonly come with pain down their arm and numbness and sometimes weakness of the muscles of the hands. And when the spinal cord is involved, they get upper motor neuron signs of the lower limbs, and they can come to us with abnormalities in the gait, frequent falls, and if it is very serious compression, even sphincter disturbances. Let us not forget the vertebral arteries. If the arteries are kinked in cervical spondylosis, the intervertebral disc get narrowed. So what happens is with time, when you get aged, the narrowing of the disc spaces will make the cervical spine shorter, and when the cervical spine gets shorter, the vertebral arteries get kinked. And from our basic pathology, you are quite aware that whenever artery is kinked, the bent sides of the artery, the intima, undergoes some changes and small platelet plaques are produced. So you can get little platelet emboli being shot from these little kinked sites, and that can lead to dizziness because the vertebral artery supplies a brain stem. In the brain stem, there's an important structure called the ascending reticular formation, which keeps us quite alert and conscious, and when there is ischemia of the ascending reticular formation, people get dizzy spells or fainting attacks. So having understood the causes, the anatomy and the anatomical correlation, let us try to understand as to how we would manage a person who comes to us with neck pain. As a doctor, as a general practitioner, when a person comes with neck pain, your primary role is to find out what structures are mainly involved. As I told you earlier, is it only the joints, muscles, and the tendons? Or could it be a little bit more than that? Apart from these, are the little nerve roots involved? Or could the underlying cause involve the spinal cord? So you have to see whether the neurological structures are involved. You have to ask yourself, there are 2 vertebral arteries going on inside. Are they also involved? So you have to find out what structures are involved. Then also you have to ask, although this patient comes with neck pain, could it be that he is having a generalized illness like a malignancy or an infection where the neck pain is part of the illness? So these are the questions which should run through your mind when you are evaluating your patients with neck pain. So how am I going to find answers for these questions? The only way, the one and only way, is a good clinical evaluation. I want to emphasize the point that although we talk about high technology like MRI, PET scans, CT scans, none of them, I'll repeat again, none of them can answer these questions. The only way you can answer these questions is by doing a good clinical evaluation. So we follow what we have been taught in undergraduate days. We take a history and a good examination. History, what are the points we are going to emphasize in order to find answers? Of course, we talk a little bit about the neck, get the patient to come out, with the information he has got about the neck. Radiation is very important. Please remember, if a nerve root is involved, if there's a radiculopathy, the pain should radiate below the elbow. That's one point I want to tell you. Neck pain commonly shoots down the arm. Most of our patients says, you have to ask, well, tell me, where exactly does this pain stop? If they say it is above the elbow, it is just a pain radiating from the neck or from the trapezius muscle. If the pain goes below the elbow, if the pain radiates below the elbow, it is a radiculopathy. One point worth remembering. Then, of course, you ask about neck movements, what happens to your pain during neck movements, and also you have to ask for the associated features. Are the nerve roots getting compressed? So is there numbness in the hand? Are the vertebral arteries involved? Have you got fainting attacks? Could the spinal cord getting involved? Have you got any problems with gait? Are there frequent falls? So keep on asking these questions, and the answers will give you some clue as to what structures are involved. Knowing that neck pain can be a feature of a generalized illness, particularly malignancies, infections, you had always ask for history of fever, particularly with chills, loss of appetite, and loss of weight. This is a must, particularly from the elderly patients who come to you with neck pain. Past history is very important about neck injuries. You heard about whiplash injuries, so just find out whether there's anything of that sort happening there. Of course, about oral and throat surgery. Just 3 months back, I got a 35-year-old girl who came to me after she had undergone surgery for tonsils. A tonsillectomy was done and she was in extremely severe pain. She had high fever and the MRI showed a nice prevertebral abscess there. So it's very important to ask about surgery, rheumatoid arthritis. All these questions are asked in order to answer the questions I have put before. Psoriasis or ankylosing spondylitis is very important. Both these conditions are categorized under a heading called spondyloarthropathy because these are a group of autoimmune diseases which particularly attacks the joints of the spine. So you can ask, have you got psoriasis or have any of your family members got psoriasis? If the answer is yes, you have to think, could it be that the neck pain is due to a spondyloarthropathy? Social history is extremely important. We're talking about posture. So to ask them, just asking them, or if the patient says, I'm a secretary, that's not what you need. You have to ask, how much time do you spend at your computer? The postures have to be very clearly asked for. Driving, how long does it take for you to drive from your house to the office? So all the such postures have to be inquired in great detail. Then, of course, having got all the information, you go to quick examination. Like any other joint, you have to examine the cervical spine in great detail. You follow the look, feel, and move concepts when you're examining that. And as I told you earlier, since science tells us that the commonest nerve roots which are involved in cervical spine, particularly related to a physical load, is C5, C6, and C7, all your neck pain patients, you must look for any evidence of C5, C6, C7 involvement through the sensory system or the motor system. So therefore, you have to do a good neurological assessment of the upper limbs in order to find out whether there's any evidence of radiculopathy associated with the person's underlying problem. Then, of course, knowing that there's the spinal cord, which is closely related to the cervical spine, particularly the patient talks about frequent falls, abnormal gait, you have to do a quick neurological assessment of the lower limbs, at least look for the reflexes and outgoing planters to see whether there's evidence of cervical myelopathy. Then, of course, shoulders. Remember, the cervical spine and the two shoulders, when I teach my medical students, and my professor always say, it's like a triangle. The neck and the two shoulders are very closely linked to each other, neurologically as well as through the muscular system. So therefore, whenever you get a neck pain, you have to examine the two shoulders and vice versa. Anyone coming to you with a shoulder pain, your examination is not complete unless you examine the cervical spine and the unaffected shoulder. So having taken a good history, done a detailed evaluation, your next question is, can I manage this patient in my GP practice or have I got to refer the patient? That's the first question. Like for any other patient, you have to ask yourself, am I going to keep him or am I going to refer the patient to another person? When are you going to refer? Well, in your clinical evaluation, if you conclude or if you think that the patient has got a serious illness, you have to refer them. What do you mean by serious diseases? Yes, if your patient has any clinical features suggestive of polymyalgia rheumatica or giant cell arthritis. For example, if your patient is about the age of 50 years and with the neck pain, if he also says that his hips and shoulders are stiff, doctor, when I wake up in the morning, I can't even roll in the bed. Someone has to pull me up. And for about 1 or 2 hours till I brush my teeth and wash my face, my shoulders and my hips are very stiff. That type of story. Or blurring of vision or tongue claudication, you have to think of polymyalgia rheumatica. Those had to be immediately referred with a referral letter. A patient who has got rheumatoid arthritis, you are examining your patient. You examine the upper limbs, and if you see a lot of deformities in the hand and the feet, the patient comes limping, a lot of rheumatoid deformities, neck pain, immediately you have to refer the patient to a rheumatologist, preferably with the X-ray of the cervical spine. Then, of course, along the chest pain, the patient has got any evidence of infection. Yes, doctor, I forgot to tell you, for the last 3 days I'm very ill. I have high fever with chills and rigors, and any evidence of infection, those patients too need to be referred to the relevant authorities. And also the patient says he or she has got, or in a physical examination, if there's any involvement of myelopathy, those patients also need referred to the neurosurgeons for immediate action. Another important physical sign that you should not forget to elicit in these patients the Lalith phenomena, where you really gradually, sort of slowly flex the neck and ask whether there's electrical sensation going down the arms or going down the spine. And if this sign is positive, this is another indication for you to transfer the patient to a neurologist or to a neurosurgeon for further management. Fine, so now you have selected your patients. So there are some patients where you don't want to keep with you because they need more specialized care, so you have transferred them out. And there will be a fair number of patients who are remaining with you who are not having any problems, and how are you going to manage them? Well, first and foremost, in the management, you have to do certain investigations. I purposely thought of bringing this slide in because it is sad to note that today, in our country, many of these patients are over-investigated. I'm sad to say most patients have to undergo MRI, which are extremely costly, and there are some situations where MRI does not give anything more than what you have found clinically, and even X-rays are taken to that matter. So today there are many academic colleges who have given guidelines telling us, reminding us on what type of patient you need to do a study on imaging, a cervical, even an X-ray cervical spine. Firstly, if an elderly person comes to you and tells you, this is the first time I'm dealing with neck pain, I think it is reasonable to take X-ray. But if he says, well, doctor, for the last 6 years I have been getting it, for 2 years I was fine, and last year I went overseas to see my daughter, and now since the time I came back I'm having pain, that type of story, I don't think it's necessary to do extra cervical spine. And of course, if there's any in your history, an examination, there's infection or malignancy, you have to immediately do imaging studies. And also, any patient with your treatment, if they are not responding after about 2 months, I think it's worth doing X-ray to see if there's anything happening which you have missed in your clinical evaluation. So there are very clear-cut indications telling us, reminding us what type of patients need imaging studies. Having done the image investigations, let us try to understand how are we going to treat them. What are the goals? Here we have a patient who come to us with neck pain, and some of them have pain shooting down their arm and numbness. Because of that, most of them cannot do their day-to-day activities. They are quite disturbed. So all those problems have to be addressed in our management package. Not only the pain, you have to also look at the other functional aspects as well. So how are we going to treat? Neck pain, the drugs will take only about 50%, but a lot of other things you have got to do. And I thought I'd spend a few minutes with the non-pharmacological treatment. Postural modification is extremely important. I personally feel that if you get a patient comes to you with neck pain, if you do not address this issue, if you do not talk to them about and educate them about posture, I think your management is incomplete. It's very, very bad. You have to take some time and talk about posture. We do spend a lot of time seated. So I think I'd strongly advise you to have some pictures with you. Those who are carrying laptops in our consultation room can have some pictures and show them what the correct posture is. Or sometimes what I do is, some of the IT guys, I get them to sit in front of me and I say, tell me, show me how you use the computer. I ask about the chair, I ask about the posture. I think you have to spend some time, particularly if you get a young person. Today in neurological fields, they are going to define a neck pain in young. NPY, they say, NPY syndrome. It's very common. All the world globally, they have seen it. People in 20s and 30s, their whole life is ruined. They are suffering of neck pain, and they talk a lot about educating them on posture. So spend some time about posture. Sleeping posture, how they should watch TV. If they want to nicely lie down the sofa, there's a way of doing it. Always the theory is the whole neck, cervical spine should be supported. The arms too should be supported. If you get your arms to hang down, your arms are pulling the trapezius muscle, and that can lead to pain. So spend some time about talking about posture. And also carrying bags. I'm sad to say today, due to various reasons, people carry very heavy bags. That also should be discouraged. Either they should distribute equal weights on either side, or they should use a cart or something or the other. At least address that issue and make them understand that those simple things, going marketing and carrying a lot of heavy things too, contribute or disturb the healing process. Sleeping position is extremely important. It's very important to teach them how to sleep properly. Today we encourage the neck roll. This is what I call as a neck roll. If you are sleeping, if you are lying down supine, always make sure that you keep a rolled towel or a roll sheet under your neck. You can do it yourself. It's extreme, it's very comfortable. It's quite relaxing rather than sleeping like this. This causes a loading on the cervical spine. Same when you are lying to a side. Most of us sleep lying to a side. And some patients come and tell me, Doctor, but that can be more injurious. You can see the head is dropping down. You must educate them the importance of keeping the spine straight. So all these have to be addressed in your consultation. This is what I mean by management of the neck and not drugs. These have to be addressed. Posture. We had to talk about posture. Today many people spend hours seated watching TV, computer, talking. You have to tell them that whatever thing you do, every 15 minutes at least you must move the neck. In teledramas, a lot of people, today we get a lot of people who are addicted to teledramas. One good thing in teledramas is every 15 minutes there's an ad coming in. I like it. Some of my relations, they always curse the TV also. I say it's nice because the ad is there to move your neck. But it's sad people open their mouth and get more attracted to the ad more than the story. So remember, when you are watching a TV or a soap opera or whatever, when there's an ad, you have to move the neck during that time. That's a reminder to tell you, to deviate, to take your mind away from the story or what's happening there. Same with the cricket match. When they are sort of changing after the end of one over, rather than looking at the advertisement, that's the time to move your neck. This little advice goes a long way. Then, of course, there are drugs we use. We use a lot of analgesics. Paracetamol is a drug of choice. If they are not responding very well, you can give NSAIDs. You should keep in mind the many side effects you get with NSAIDs, so you have to always match it with the patient, ask for gastritis, heart diseases, and renal diseases. And those who do not respond to those, you can use opioids. If they are, you can use mild opioids like codeine. Today we have paracetamol codeine combinations in the market. We can use them, and if they have a lot of pain, you can go to strong opioids like tramadol. And also, muscle relaxants sometimes work very well in your examination. When you are touching the neck with the fingertips, if you feel many areas of, sometimes you nicely feel through the muscle, you can feel knobby, hard areas which are tender. Those are the muscle spasms. Usually most of them recover with hot fermenting. That's one thing I remember. The best treatment of muscle spasm is hot fermenting, and avoid any blow hitting the neck. AC blow, fan blows, and we know in a bus or a car, if the blow hits on neck, all the muscles are going to spasm. So just putting them into some heat treatment helps them, but if still it doesn't help, you can use a muscle relaxant like cyclobenzaprine. Those can be used. And of course, if there are significant disturbance or sleep like insomnia, antidepressants are being used. If there's radiculopathy, which is significant, sometimes we use drugs like gabapentin, not forgetting that all these drugs have a lot of side effects. You have to educate and tell the patient about them. Then, of course, there's a home exercise program. Remember, when you get a neck pain and when the patient responds, that's not the end of the story. About 90% of them recur again and again and again. So you have to ask the patient, please ask your patient to report back to you when the patient is quite all right, because you have to then teach him another set of things to prevent this patient getting again. So these are the stretching exercises. So since you all are feeling sleepy, I thought I'll demonstrate with you. It's good for all of us. I do it myself. Therefore, I don't get any neck pain at all. I do this exercise, stretching, twice a day in the morning before I go to work and once I return home before I go to bed. And one is a neck rotation. You can do it with me. All what you do is you go into full rotation to the left or the right, and with your hand. This should be done if you have any severe pain. You should not do it. But those who don't have pain or mild pain can do it. You look straight and you look to the extreme left, and with the hand you give a gentle push, and you hold it for about 5 seconds. 1, 2, 3, 4, 5, and slowly go to the other extreme, and with that hand you push it that way and hold it for 5 seconds. That's the rotational stretching exercise. Then the tilting, you hold the neck like that. I think those are going to gyms. Your trainers will have trained you. That's what we always do before we do our exercises. You hold it like that for about 5 seconds again, and you gently release your hand, and then you have to stretch it that way. And you have to always hold it at least for 5 to 10 seconds. That's very important. A gentle stretch, but stretch it firmly. You need it. Then, of course, the neck bending exercise, you get the patient to touch the chest with the patient's chin and again hold for about 5 minutes. And yes, and remember, you don't do much extension because elderly people who have got vertebral artery problems, there can be problems. You always go to the rotation, then you go to the lateral flexion and bending. Those are 3 movements we do. You have to do at least 3 sets in the morning and 3 sets at night. If you do it routinely like brushing our teeth, take my word, you should not get backache at all. You should not get neck pain at all. It keeps our neck quite healthy. Then, of course, this is another very important one for those who do a lot of work with the computer, because you can see me when I am seated and doing my work, always my shoulders are shrugging down, my structures are pulled down. So you have to do a lot of work to strengthen. So what you do is the shrugging, you take it up like that, and you have to take the shoulder back. You have to bring the shoulder base together. That's the important thing. I throw it from here. You take it up and take it back, and you hold for 5 seconds. It's very soothing when you do that. Hold for 5 seconds. You repeat it about 4 times. The shoulder rollings is very important for people who do a lot of work seated, because the trapezius, I'm thinking most of you must have felt pain in the trapezius region, because it's always pulled. So always you take it up, then you have to shrug it as much as possible. Try to bring the 2 shoulder blades together and hold for about 5 seconds. Repeat about 4 times. If you can do this exercise and teach your patients who have got mechanical neck pain, I think they should not get it again. Collars. A lot of people ask me about collars. Unfortunately or fortunately, there's medical evidence does not, we are practicing evidence-based medicine, they do not support the cervical collar much. Well, there's a scientific theory behind that, because when you use a cervical collar, what happens is your chin is always resting on the collar. Now, when I'm without a collar, the gravity always pulls my neck down, and always my back muscles have to always work to keep my neck straight, or my chin straight. So when you use a collar, what happens is the muscles are not being used much, and as a result, your neck muscles undergo wasting. When the neck muscles undergo wasting, that disturbs the stability of the cervical spine, which in turn can lead to many problems. That's one. The second interesting thing is, about 10-15 years back, research done in sports medicine, they found that when your neck muscles get weak and wasted, your coordination becomes very poor. They did a very interesting research study. They took 2 cohorts of university students. In one group, they asked them to wear a collar for about 1 month. The other group were just allowed to just go on with their normal work, and they were put into various sporting activities. Their ability to hit targets like tennis, badminton, then cricket, betting, all those were quite disturbed in those who were wearing a collar. And added to that, another research showed that elderly people who were using collars on a long-term basis had a lot of road traffic accidents when they were crossing the road. They could not judge the vehicle and the time of crossing the road. So today people feel that if your neck muscles are getting wasted or weak, not only they give stability to the neck, but they have a role. The proprioceptive fibers from the cervical muscles do play a very important role in very, very precise coordination. So those also can get disturbed. So therefore, we do not encourage collars much. When will I give a collar? If the patient is in severe pain, yes, I will give it, but that is also not for the whole day. You say 3 hours on and 2 hours off. We are for 3 hours, be without it for 2 hours, like that you can go on. The only indication to use a collar continuously is, one, if there's a rheumatoid neck, like atlantoaxial subluxation or subluxation below. And the other place is if you have a fracture, even a hairline fracture of the cervical spine, I will want my patient to wear the collar, because neck being the most mobile part of the spine, the hairline fracture can spread. So those are 2 places where we always put them on permanent collars, nothing else. And all the neck pains you had to always tell. And people get used to it. Some other people, I have very great difficulty in weaning it off. So due to these reasons, we don't encourage a collar much. Surgery. I am a physician, you know, but there are times where we have to get the assistance of our surgical colleagues to treat these patients. As I told you earlier, if there's any neck pain with sphincter involvement, doctor, you know, I developed this pain about 2 weeks back, but it's very funny, over the last 3-4 days, I can't control my bladder. I have retention, or I pass urine unknowingly. I can't control my bowels. That of our story, immediately you have to send them to relieve the pressure on the spinal cord, and severe radiculopathy. If a radiculopathy is not responding to the drugs you are giving and the physiotherapy, even we refer our patients to our colleagues. So those are the 2 main indications for referring our patients to surgeons. So since I have come to the end of my short lecture, I think I should thank you once again for your patient listening, and I would summarize that neck pain is a very common symptom. And the only way out is not an MRI scan, not a CT scan. The only way out is a very detailed clinical evaluation. Please spend some time. If you are very busy, get the patient to come the following day. You have to spend some time. It's worth. You can do wonders with the patient. And most neck pain is postural, bad posture. They don't know how to sit, they don't know how to sleep, they don't know how to keep their neck. Therefore, the posture has to be addressed. That should be one of the important areas that you have to cover in the management package. And treatment is very simple. Thank you very much.